Morning, Center Stagers. Welcome to Dr. J's Prescription for Health. I am your host, Dr. Malea Jensen. I am a family practice physician. I'm located in Des Moines, Iowa. For those of you who do not already know, my co-host, Tucker, he passed away in February earlier this year. So Tucker used to be on my live streams with me. And now he's still with me, but he's co-hosting from heaven. So this is Tucker. And yeah, I miss him. I love him. And he's with us still answering questions and helping me answer questions. So this is your opportunity. Good morning, Cami and Virginia. Looks like we got a lot joining today. Happy day after Thanksgiving, a couple days after Thanksgiving. Hopefully you guys had a great Thanksgiving and we're very thankful. So this is your opportunity if you want to ask questions. Again, this is not medical advice. It's for information purposes only. A little bit of entertainment intertwined, but yeah, not medical advice. So that's where your personal doctor comes into play. This is where you are able to ask questions, learn a little bit, and then take the information that you have gleaned from these live streams, take them back to your doctor and discuss them. That's how it works. Or don't have a doctor at all, right? I mean, that's how some of you work. I'm not opposed to that. I'm not for that. I'm just giving you guys information. So if there's no questions right now, what I had planned was to talk about something that has come up several times in consultations this past week. So, and it is in regards to ApoB. Now, many of you say or think that ApoB, if ApoB is a certain level, it will either tell you that you are at risk for a heart attack or tell you that you're not at risk for a heart attack. And I think we should know a little bit about what ApoB is before we can make any decisions. ApoB is a protein that is attached to lipoproteins. Lipoproteins means a fatty protein. ApoB is another type of, it's not a particle, it is attached to the lipoproteins, including VLDL, IDL, so very low dense lipoproteins, intermediate density lipoproteins, IDLs, and LDL itself, so a low density lipoprotein, and Lp(a). So if we were to add up all of the ApoBs, it would include the VLDL, the IDL, the LDL, and the Lp(a)s. So basically across the board, LDLs. So is it a little more informative than simply getting a lipid panel? I say yes. Now, you can talk to your doctor about getting it. I don't know where they're at in this progression, medical progression and information, but you can ask for it. Your LDL that is on the lipid panel. So when you get a cholesterol panel, it gives an LDL, well, it gives a total cholesterol, an LDL, an HDL, a triglycerides, and a lot of times they will calculate a non-HDL or a cholesterol to HDL ratio. Not all the panels do it, but you can simply calculate it yourself. Where this falls victim on giving you information is LDL. LDL is a calculated version of LDL. The LDL that's on your lipid panel is calculated by something called a Friedewald equation, where LDL equals a total cholesterol minus HDL minus, in parentheses, the triglyceride divided by 5. So LDL equals total cholesterol minus HDL minus, in parentheses, triglycerides divided by 5. it is inaccurate if triglycerides are over 150. If your triglycerides on that lipid panel are over 150, the LDL calculation is inaccurate. It also assumes, it basically assumes that this equation assumes that triglycerides are fixed. And we get that, you can see that when you look at the triglycerides divide by 5. Why isn't it 4? Why isn't it 3? Why isn't it 10? So it appears that the equation treats triglycerides as if it's a fixed entity. But you need to know that if you look at your lipid panel and it is, your triglycerides are over 150, then you can't really look at your LDL level as being, let me see. I am going to get rid of that one. Let's see. We're going to get our moderator going here on YouTube. Appears that we got more riffraff. Let me see. Okay. So when discussing LDL, we have to know that on a lipid panel, it is calculated. Could you get a direct LDL? Yes. When do I order a direct LDL? When I know that patients have a high triglyceride level. If I know that their triglyceride level is extremely high, it's sometimes up towards to 300 or more, I don't know their LDL. These people usually see a cardiologist as well. But those favoring, let's just say that you did get an ApoB. Those favoring getting an ApoB will say it counts all atherogenic particles with accuracy. So what that, if you come across a doctor who tells you that ApoB is really the only thing you need, it's because they think ApoB counts all atherogenic particles. And they're assuming that all LDLs are atherogenic. Now, that's going to presuppose that LDL is, or VLDL or IDL are all atherogenic. So you have to believe that that is accurate. If you say, hey, wait a second, I'm not so sure I can get on board that all LDLs are atherogenic. I can maybe get on board and say that the small dense LDLs that I've been learning about, and even the LP little a's, are atherogenic. But even the light and fluffy ones, what if we got rid of all of our LDLs? Are they really needed? Some would say, well, I think LDLs are necessary for life, doctor, but are they all atherogenic? And I might be in the camp with you out there who say, I'm not so sure all of them are atherogenic. We need LDLs for delivery of cholesterol to the peripheral tissues, for cell membrane, for carrying fat-soluble vitamins and hormones, and our immune system, and binding to bacterial toxins. All of the things that LDL do, are they all bad, and should we essentially lower them because ApoB is high? These are things that we need to ask not only ourselves, but also our doctors, and really do some extracurricular reading. Is there a time where LDL, let's just say, because here's where I have a conundrum. how come heart attacks are still occurring in people who have low LDL? Either they're just naturally have low LDL or they're on a statin. Why is it that LDLs are low and people still have a heart attack? My best answer could be this. Remember I told you initially when we first started this that ApoB is attached to VLDL, IDL, LDL, LP little a. If statins only lower LDL, we still have VLDL, IDL, and LP little a that could increase our risk of cardiovascular disease. And thus, even though LDL is low, ApoB can be high. ApoB can be high in the presence of low LDL. So what should we really be looking at? I mean, I don't know the answer, but I'm trying to get you guys to think, but what if we looked at VLDL? What if we looked at IDL? What if we looked at LP little a? Maybe that's the direction we should be going. What if we do look at VLDL? I mean, I've had people today even tell me that they don't believe VLDL exists. Well, then they obviously don't believe that triglycerides exist, because VLDL and triglycerides are literally one and the same. So if you could still have a heart attack on a statin, even though LDLs are low, what is the answer? Is the answer to lower VLDL or even IDL? I think yes. Well, how do we lower VLDL? Any takers on that? The way we lower VLDL is a low or no carb diet. No alcohol. Alcohol is a carb. Those raise triglycerides. Carbs, alcohol, which is a carb, raises triglycerides. That's VLDL. VLDL carries triglycerides. So should doctors be telling their patients to lower their carbohydrates instead of jumping to statins, which simply lower LDL, and don't maybe treat the higher risk of cardiovascular disease, the VLDLs, the triglycerides, the IDLs, the LP little a's? I don't know the answer, but I do know that I have seen people have heart attacks that have low LDL, and they've been on statins for years. It's something to keep in the back of your head when you are asking your doctor for an ApoB and you freak out because it's high. I would steer you to looking at your triglyceride level. I would also steer you to looking at your HDL level. I am still on board with checking a triglyceride to HDL ratio. If that ratio is over, let me see where we got here. I don't want to miss anybody talking, sending questions. Okay. If that ratio of triglyceride to HDL is over 2, I believe we have a problem and you are a setup for cardiovascular disease. I believe that the fastest, most powerful way to lower ApoB in a majority, I didn't say all, I said a majority of people without drugs, is to remove the drivers of high VLDL. I believe that. Until I've been proven otherwise, I believe that. Because here's one of the things I believe is, the number one cause, if you look at everybody who has a heart attack, let's just take the panel out of the arena. There's no lipid panel. And we tested everybody who's had a heart attack. I think there's going to be two things in common. Number one, they have diabetes. Or number two, they have prediabetes. They have insulin resistance. If you get an insulin level on every heart attack victim, I presume, speculate it's higher than 5. No matter what their panel says. But extracting that back, I would look at their panel and I would see that they had high triglycerides and low HDL. I would see that their triglyceride to HDL ratio is over 2, over 1. Diabetes is the number one cause. If you look in a hierarchy and you Google, what are the number one causes of coronary artery disease? Is LDL on that list? And if so, how far down the list? Is it metabolic syndrome, which includes high blood pressure, high triglycerides, high blood sugar, high waist size, low HDL? Is anywhere in that metabolic syndrome LDL? No, it seems odd that they didn't mention that, right? So my thinking is, how do we achieve an ApoB in the range where they want it to be, say 70? How do we achieve that? I believe the easiest way is a low-carb keto diet routinely. I think that if your trig level, if your ApoB is in that range, your triglycerides will be 70 or less. You're on this keto diet, your LDL could be sky high, but your ApoB is low because VLDL production is almost shut off. Is it possible that because the VLDL is shut off, your risks of having coronary artery disease or a cardiovascular accident is much, much lower? It's possible. Again, these people with the high LDLs on a carnivore or low carb diet, it's a conundrum for sure. And I use a lot of things to see the whole picture, including a calcium scoring test. Because there's a lot of people who have high LDL and very low triglycerides, very low VLDL, high HDL. They exercise, they eat a lot of fat and their saturated fat in their diet, and their HDLs are very high. Their scores, their calcium scores are 0 in the presence of very, very high LDL. I don't know I'm telling you right now, I don't know the answer. Because the people who favor the ApoB, which I'm not opposed to, as long as you can help explain it to the patients on what it's measuring and why it's like kind of, it's hard to read. It could go back and forth. Well, ApoB is high, it could be normal high in this part or this instance, but high in this instance is damaging to the arteries. I think if your physician believes in the saturated fat heart hypothesis or the heart LDL hypothesis, then a high ApoB will trigger them to put you on medications. And so you have to be well informed to say, yeah, but, or ask a question. That is where what we're not doing is asking questions. Because here's something I just want you to think about. these LDL supporters who also support the ApoB will tell you that LDL is the cause of cardiovascular disease. Okay? Why do they say that LDL is the cause of cardiovascular disease? Because studies have shown that when you dissect an artery or you look at autopsies of these people, they will have coronary artery disease and LDL will be present. They wholeheartedly believe that LDL is the cause of the actual damage to the artery. Now, what I want you to keep in mind is an LDL particle nanometers are hard to understand, but an LDL particle is between 21 and 25 nanometers. Let's just say inches, 21 to 25 inches, or something that you can, if you don't understand nanometers, just remove that, the descriptor, and just say an LDL is the size of 21 to 25. And a small, dense LDL, the smallest guys, are 18 to 21. When the lining of your artery has a glycocalyx on the innermost aspect and then a single layer of endothelial cells, and those endothelial cells are butted up against each other, and they don't like things to go between them. They want a tight junction. Okay, what makes the tight junction not so tight? Inflammation. But let's get back. The junction here, guess how many nanometers it is? 4 to 6. If the gap junction, the tight junction, is only 4 to 6 nanometers, do you think that a small, dense LDL, which is 18 to 21, could go through that junction? No. Could an LDL of 21 to 25 go through that junction? No. But let's say you have inflammation, and inflammation causes a gap junction, anywhere from 20 to 100. So now, could an LDL get through that junction? Theoretically, yes. And if the gap junction was caused by inflammation, what is causing the inflammation? Sugar, alcohol, nanoplastics, nicotine, tobacco? What about sickle cell disease? Shaped, oddly or sickle-shaped red blood cells that go in and destroy or cause inflammation, like a cut on the inner lining of the artery. Does an LDL itself cause inflammation? I think not. I think it's anti-inflammatory. I think it helps patch up or heal an injury or inflammation. But I don't think that LDLs could keep up with the amount of trauma that's going on. Okay, so if we have so much trauma by those other things, by the inflammatory condition of smoking, alcohol, sugar, nanoplastics, microplastics, those things, constantly causing inflammation and then healing trying to occur. When healing is occurring, yes, I believe there is blood clot formation. Those blood clots could be stable or unstable. They could be around for a lot of years, or they can regress as long as the inflammation trigger is removed. If I keep scratching the back of my hand, that will never heal. A chronic scab will occur. A chronic blood clot will occur. Eventually, that blood clot could become calcified, hardened like a scar, over and over and over again. I believe at this moment that plaque begets plaque. So if you have plaque, it could be triggering more plaque. Is that plaque a sign of inflammation, and then we have more things coming to as an anti-inflammatory or as a healer? Yeah, I think it's possible. So is it something that we need to think about, that if we could lower those inflammatory things, low sugar, which would be a low no carb diet, which would decrease LDLs and VLDL, or excuse me, VLDLs and triglycerides, right? Because a VLDL carries triglycerides. If we lower our carbs, we're going to lower the VLDL triglyceride. If we lower our carbs and raise our fat, we're going to raise HDL. And now our ratio becomes intact. And our ApoB, which I'm not opposed to having some emphasis on this whole marker thing, but it becomes a non-issue. Can plaque regress? I believe it can. I've seen it regress. I've also seen it go up, even in the presence of low LDL. I have seen it go up in people who are on medications that lower LDL, and the plaque continues to grow. Now, is it growing because of the statin, or is it growing because of the diet, the high sugar diet? That person has insulin resistance. The sugar continues to damage and cause high VLDL, high triglycerides, and damage the lining of the artery, despite the fact that LDLs are like 50 with a statin or a PCSK9 inhibitor. These are just things that you guys need to think about instead of just jumping on board with the LDL is the cause of heart disease boat. Use some discernment and say, but what if? Dr. Jensen, can you make me a YouTube moderator, please? I am tired of the YouTube riffraff distracting. Yeah, for right now, you can be, can manage blocked words and change chat in live, and also has capability as a standard moderator. Okay, there you go. RM, there you go. So do your thing. In case you guys don't know, I am live on Instagram and Facebook. If you guys have a question, please put a Q in front and maybe a Q in after. Arizona Nana Ruth says, what is the best way to reduce your LDL? My question back to you is, why do you want to lower your LDL? What is it about your LDL that you want to lower? If you want to lower the particle size that you think is the cause of coronary artery disease, I would draw your attention to lowering small, dense LDLs. Small, dense LDLs. Do we want to lower all of our LDLs? Well, then you would get into a position where that is not compatible with life. We need LDL for cell membranes. We need it for sex hormone production. We need it to carry fat-soluble vitamins. We need it to initiate our immune system. So I believe that if you had low or no LDLs, you are putting yourself at risk and decreasing your longevity. But if you say, okay, I want to rephrase my question, Dr. Jensen. I want to get rid of the small dense LDLs, the ones that you say are the lower on the particle size. Well, again, even a small dense LDLs, I don't believe gets through the tight junction of the endothelial cells in the lining of the artery. So what would a comeback be of a person who is LDL, who speculates that LDL or is so on board, they see no other reasoning that LDL is the cause? And I told them about the tight junctions. How would they defend this? They're going to tell you and me that those LDLs don't go between the tight junctions. I can agree with you there. They go through the cell membrane of the cell. They're going to go through these guys. How? They're going to go through them because on the cell membrane of these endothelial cells are receptors that take in or accept LDLs. Is it possible? Sure it is. That means that they have to go, so how do I explain? This is the inner lining of the artery on the inside. I'm looking, it's hard to explain, but I'm going to try to picture the internal lining of an artery, of a tube. And on this inner lining is the glycocalyx. And then you'll have the endothelial lining, that one cell layer thick. And if they're going to agree, the proponents of LDLs causing a heart attack, they're going to agree that LDL particles, no matter what size of LDL particle, it is too big to go between the cells themselves, but it can go through the cells themselves. So they're going to go through the front side of the membrane, and then they're going to crawl through this cell like a little ninja and exit the other aspect of this cell. So that means there has to be a receptor that takes them in and a receptor that spits them out, because they're saying that the plaque happens way over here, not in the internal lining. So it's glycocalyx. So you have to destroy the glycocalyx first, if they believe that that's there. Then you have to go through the cell membrane of the cells, can't go between them. We already proven that, and they're going to agree. So they're going to go through them. The LDLs are going to go through them. So a receptor has to be on this surface membrane and suck them in, accept them, and then it's going to crawl through, that LDL is going to crawl through the whole cell and enter the back door, and some receptor is going to spit them into the other lining still inside the artery, but on the outermost lining of the artery, deposit itself and attract a bunch of blood cells and debris. Now remember, the blood cells and debris are in here. So are they going to crawl through and do the whole thing and start the plaque over here? I mean, I'm just thinking here. I'm just trying to see where these people are coming from. But why don't you imagine something that's a little more believable? That we have the artery, we have the glycocalyx, we have the next layer, the endothelial cells, and then you have another layer, say, and then you have the outer aspect of the artery. What if something in the bloodstream irritates that glycocalyx? And then the glycocalyx is thinned, now it's not there. And then it injures the endothelial cells. Now that injury could be to the cell membrane, like oxidation. And if those cells are injured, can they repair themselves? I say yes, because there are stem cell progenitor, little baby endothelial cells that are produced in the bone marrow that get made, little babies, and those little baby cells go and replace injured endothelial cells. That I can see as a normal process. But what if the injury overwhelmed the progenitor baby cells? They couldn't keep up. And so that damage to the endothelial cells got worse. And then the natural mechanism of the body is to repair it. So we have some inflammation. We got irritation. We got a cut. And a blood clot forms. And that blood clot attracts a bunch of debris like platelets and white blood cells and red blood cells and all of the things. I mean, can you see that happening? You're in the middle, you're in the lining of the artery, you're inside floating around. And something, sugar, tobacco, smoking, alcohol, nanoplastics, they're all damaging the glycocalyx, then damaging the endothelial lining. The body tries to keep up, but can't. So a blood clot forms, like a scab, and then that blood clot attracts more things. Could be LDLs, right? Could be LDLs, could be all of those things, platelets and white blood cells and all kinds of debris to harden that plaque, to protect it. But if the injury continues, could you see where not even the blood clot can keep up? And so a blood clot forms on the inner lining, a blood clot forms, it attracts all this, it patches it up, injury keeps occurring, so another and another and another, and finally you got a plaque in your arteries that closed it up. I think it's plausible. And the reason I think it's plausible and not LDL causing injury is because LDL is not just in the arteries of the heart. It's not just in the arteries of our neck. It's not just in the arteries of our legs or our hands. It's everywhere. LDL is flowing in the bloodstream. If it's flowing in the bloodstream, it's also present in veins. Why doesn't LDL cause a problem in veins? Why is it only in arteries? A good comeback would be, oh, Dr. Jensen, I'm glad you brought this up. It could be in the veins. And the reason it doesn't cause problems in the veins is because of the purely sheer force that is occurring in arteries that doesn't occur in veins. And that sheer force could be blood pressure elevations, right? And a good comeback might say, because of the sheer force, it's going to occur wherever there's a bifurcation. So if you got an artery and it's flowing and flowing and then it bifurcates, that little Y is the highest area of sheer force. You got a whole bunch of blood going this way, and then it either goes this way or that way. That pressure pushing it, bam, that's where most times cardiovascular disease occurs, is in areas of bifurcation, high shear forces. And that's where that plaquing is going to occur. There are the three main arteries that plaque loves our heart is the left anterior descending, the right coronary, and the circumflex. And there's parts of those three main vessels that are more susceptible because of shearing forces But that artery, in order to cause a blockage of flow, would need to be upwards to 70% blocked by what they call the plaque. You're not going to block blood flow at 50% or 49%. That's why I could not figure out back in my day, I didn't understand why cardiologists would leave your coronary arteries at, if it's less than 49%, don't worry about it. But they never really explained why. Because their blood flow is still going through there. If it was 70%, now they're going to take you to surgery. But because it's 49, 50%, and statistics say that they're not going to have decrease or a blockage of blood flow until it gets past 70. Now, the beauty of it is that this takes years to occur, to get to that 70 or greater. That's why nobody gets a calcium scoring test at 20 years old. They're going to do calcium scoring tests on your 50-year-old, your 60-year-old. They're going to say, oh gosh, you're over 70% blocked. You're at risk. Even though you're on a statin, lowering your LDL for years and years and years. Because it wasn't the LDL. It was the injury that caused inflammation, or inflammation and injury that caused a blood clot, right? You could even talk to the pro LDL doctor and say, okay, how come this person didn't have a heart attack and their blood flow their artery is greater than 70% blocked? They could actually get on board with collateral flow. For instance, you come across somebody and they had 100% blockages in 3 of those arteries, all 3 main arteries. Yet, none of the tissue of the heart was dead. Why? Because they had collateral flow. They branched off arteries. Because that's what the body does. If blood flow is starting to go down, then they need to branch off and get blood flow to those areas or the heart's going to die. So what could be the main cause of heart attacks? It could be the blood clot. The blood clot broke off and traveled downstream. The blood clot could be the reason. The sheer forces of the blood pressure added to that injury, and the fact that you had high blood pressure, in my mind, tells me that insulin resistance. Higher your insulin, higher your water retention, higher your salt retention, or vice versa, salt then water, which causes blood pressure elevations. And then your doctor goes and lowers your blood pressure. Well, they could say the reasoning behind it could be, well, we got to lower it because we know shear forces at bifurcations increase our risk of cardiovascular attack, an MI, myocardial infarction. But is your body with the high blood pressure telling you, hey, I need blood flow to your brain, and if you give me a blood pressure lowering medicine, now I can't get blood to your brain, and now you get cognitive decline. I mean, there's a lot to think about and why your doctor thinks the way they think. I'm one of those people that thinks in greater detail and say, hey, before we go do something, why is blah, blah, blah occurring? And then we try to work backwards. Linda says, yeah, it makes sense about blood clots. It does make sense. I mean, it kind of makes sense, right? Roadrunner, I don't understand your question. What if your sugar keeps dropping out? I don't understand your question. Olive says, doctors don't study healing, they study diagnosing. I'm not giving an out to the doctor but I'm going to agree that they weren't taught healing. They were taught diagnostics. If I make a diagnostics, I've been taught to give you a treatment based on that diagnostics. And that treatment is usually in quotations, pharmaceuticals. I have people fight me all the time, and they're usually other providers and say, doctors most often tell you about diet. Now, you guys are listening and you have high cholesterol. Did your doctor tell you that your diet is responsible for your coronary artery disease, and if you fixed your diet, you could lower your risk of coronary artery disease? Did they tell you that? And if they did tell you that, did they tell you to eat a low saturated fat diet, which is low LDL, and high vegetable and high grains? Or did they tell you that in order to lower ApoB, which they say is the problem, you lower VLDL? Well, to lower VLDL, you do a low carb diet, a low sugar diet. Whatever your doctor told you is what they believe in. If they truly believe that saturated fat and cholesterol and LDL is the cause of your coronary artery disease, despite the fact that if you lower the LDL, you could still have a heart attack. And then they will blame it on something else. They might even blame it on your diabetes. But if they blame it on their diabetes, you just caught them in a catch-22. Because if it was their diabetes, why didn't they tell you to lower your carbs? Because diabetes is a diagnosis of carbohydrate toxicity. So you could catch your doctor all the time because they're really not that educated. They're only educated on making a diagnosis and giving you the treatment that they've been taught to give you. You've been propagandized in that LDL is the only cause. In fact, I had a provider tell me that there's no such thing as VLDL. I mean, that stands in very stark contrast to a lot of other doctors. They're going way out on a limb and saying there's no such thing as VLDL. Whew. That would mean there's no triglycerides, because you don't measure triglycerides in the blood. Blood is water soluble. You can't measure cholesterol in the blood. You're measuring lipoproteins that carry triglycerides, that carry fat and cholesterol. The lipid panel is nothing more than a superficial way of looking at your risks of a heart attack. Okay? Richard, I'm not trying to put doctors down. I'm just telling you that you guys are probably more educated because you're going down little avenues. You're using your brain. Whereas a doctor gets stuck in a tunnel vision because everything that they do is promoted by guidelines. And if a guideline wants you to do something a certain way, they're going to pat you on the back and give you kudos and be your supply of, you're doing everything perfect, doctor. Keep going. You won't get sued as long as you follow the guidelines. And the guidelines say lower LDL. If you lower LDL, I'm going to pay you more. I'm going to pat you more. I'm going to love bomb you. That's what they're doing. And so what would encourage a doctor to jump out of that tunnel vision? It would take a lightning strike, to be perfectly honest. Or over and over and over, people questioning them. If patients started questioning their doctors over and over and over, I mean, totally questioning them. Maybe nicely. They might get it. Yes, Olive, they do have egos. Everybody kind of has an ego. But if a doctor spends by the time you get done, you've spent 29 years of education. You think your shit don't stink, most of them. And you think that everybody owes you everything because you did higher education. No. The doctor's the one that chose it. They chose 29 years. They chose to go into debt $200,000. They chose it. Nobody forced them. I'm going to force you to be a doctor. Yet when they get done, their ego says, you owe me. It is, yes, their ego. Yes. It takes a special breed to be that doctor and not know that you have been groomed by your parents, by your birth, by everything. You've been groomed, patted on the back, done this, and you succeed by being perfect. And then you think in order to get kudos, you need to keep performing this way. And then people will say, oh gosh, doctor, you're so smart. Thank you for saving my life. Blah, 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 whatever it is. But you're just feeding, and we call it ego, but it's this inner whatever self got fed any other way but by telling you that you have to be perfect. Those are the people who are doctors, right? And so if a doctor gets out after 29 years of education, including the residency, I'm talking total, now everybody owes them. Everybody is their supply. Everybody has to pay back their loan. Everybody has to listen to them and in a paternalistic way. Right? But sometimes the doctor, the highly educated person, becomes or snaps out of it. Somebody along the line, if the doctor has any humility, any soul in there, they could be their fortress that they built up around them could be broken. As long as that self inside them is able to break down the walls and they have humility and usually a higher spiritual being I will call God. That is why the doctor you call an ego problem. They didn't just get out of medical school, become a doctor, and they developed an ego. No, that had been developing for years and years and years, okay? And so if you find that your doctor doesn't want to order what you want done, like an ApoB, or something, they don't want to order your insulin level, they are admitting to themselves and to you that if they found something that went against what their tunnel vision told them, they would have to defend that, and they do not want to defend that. That would expose their inner self was wrong. And that exposure hurts worse than anything else. They do not want to be exposed as being wrong. Ever. Angel says she's met phenomenal, or he met phenomenal doctors, which include the patients in their diagnosis and treatment. Awesome. That's the kind of doctor you want. One that has shared decision-making. Good. I'm glad you have that experience. Let me see. Good morning, Lucy. Nancy says, do you think excessive exercising could contribute to the problem? What problem? Do I think excessive exercising could be a problem? Absolutely. Contribute to what problem? I'm assuming you mean coronary artery disease, a heart attack. Yes, I think chronic exercise elevates mTOR, and with mTOR is not allowed to come back down naturally. We need mTOR for growth. We need insulin for growth. We can't have zero mTOR and zero insulin, or we would die. mTOR goes up with exercise. mTOR goes up with eating, usually carbs. Same thing with insulin. Insulin goes up with carbs. Exercise actually helps to lower insulin because exercise makes muscles hungry for glucose. If the glucose is out of the bloodstream and into the muscles, guess what happens to insulin levels? Right, it goes down. Do I think excessive exercising that increases mTOR and does not allow mTOR to come back down like it's supposed to and stays elevated on a chronic basis? I think that's a problem. I think that chronic growth and irritation and inflammation leads to congestive heart failure and even atrial fib. It's going to hurt the muscles of the heart. It's going to hurt the electrical system of the heart. Maybe not as much as the plaquing, but honestly, I truly can get on board with that as well. Why? Go lay down. Go lay down. Because the chronic exercise is not only, it's also irritating the lining of the arteries. What could it be? The shear force and the blood pressure problem? So a person who follows a Mediterranean diet and over exercises their whole life is building plaque because of the injury and inflammation and blood clot, stabilization, calcified, blah, 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 over and over and over. That person who did all of the things, they exercised they followed low fat diet, they did all the things, and they have coronary artery disease. And they develop congestive heart failure, and they develop AFib. Just look at people in your life and start putting pieces together, okay? And see, is that, does it ring true? Because in my patient population, which I have a lot of them, I'm seeing that more and more, but I did not put that together before. It took me humbling myself with humility, listening to patients, just opening my eyes and ears to somebody else besides a 3-letter agency or the American College of Family Physicians or the AMA or whatever 3 or 4-letter agency that is setting guidelines. It takes strength and conviction to go against the grain. And could I still be wrong? Absolutely. Absolutely. Because there's so many avenues that we have to look into. We all, you and me, I'm still looking into them. You guys are listening to all these people all over. You're trying to understand, is there another way? Because you're starting to have doubts. And that gut feeling of having doubts is spurring you to listening to somebody like me, to listening to another physician or another healthcare provider that has a little bit different. Could it be the wrong, different idea? Absolutely. But it's getting you to open your brain up and start wondering, is there something else? And if diabetes, it seems like almost all doctors can get on board that if we lower diabetes, we would lower the risk of cardiovascular disease. But yet, instead of telling their patients to stop with the carbohydrate toxicity, they will give them a medicine that could possibly actually increase insulin and worsen their diabetes, i.e. a sulfonylurea, which I don't know if there are still doctors out there that use them, like glipizide or glimepiride or Amaryl. I mean, are there people still using those sulfonylureas? I don't know, because I was in practice on my own, so I don't know how doctors are treating. But what I have seen is, oh, well, let's put them on metformin. That will cause the blood sugar to be driven into, or open up the doors on cells to drive blood sugar into cells, or open up the doors on the muscle cells so sugars can drive into those areas. But what if the cells that you're trying to push sugar into are already resistant? They're full. That's why their doors were shut. Why would you give them metformin to open their doors to make the cells bigger and fatter and fuller? And if you make them bigger, fatter, fuller, they're just going to explode and release all of their inner contents, which increases more inflammation and more injury, and then more attraction of the LDLs, if you believe that's the part, and the platelets and the debris. So you take a medicine because we're glucocentric, we're just going to lower the blood sugar in the arteries, not knowing what it's causing to the fat cells or cells in general that get too big and explode their inner contents, which increases the problem even more. So if you get another smart doctor, they'll say, okay, I'm just going to go with an SGLT2, which is another diabetes medicine, right? Another diabetes medicine that tells the kidney to just spill out the blood sugar. So they didn't tell you not to eat the blood sugar. They're just going to make your kidneys pee it out. That's what an SGLT, Jardiance or Invokana or something like that, right? Farxiga. Those are SGLT2 inhibitors. So if you have a cup full of sugar, water, and it's at 500, and you want to lower it to 100, you want to get rid of 400, you give an SGLT2 and you'll pee that out. And then they'll tell you that it's not going to damage the kidney. In fact, they'll tell you that peeing it out is good for the kidney. But yet if you have diabetes, the sugar going through the kidney is really, really bad. So which is it? Is it only really, really bad when you're not on an SGLT2 and you're peeing it out? I don't understand. I don't know the answer. I'm just thinking out loud here. So again, we're glucocentric. We're going to have you pee out the sugar. Metformin pushed it into cells that might have been resistant already, and now you're making them worse. A protective mechanism of the cell was to shut its doors. I'm full. That'd be like trying to put more garbage into a room that's already full, and you open the door and you try to throw it in, and some comes back at you. That's how much trash you kept putting into the room, or the cell in this case. There's another medication called a GLP-1, and a GLP-1 will just tell you it's a diabetes medicine. But instead of 100 hot tamales, you're just going to eat 20 hot tamales. Being on a GLP didn't tell you what to eat. You just eat less of it because you get fuller faster. So instead of 100 hot tamales, you're just going to eat 20. But 20 still elevates blood sugar, and the blood sugar still promotes insulin resistance or high insulin, hyperinsulinemia, which elevates blood pressure, which causes shear force, and then the sugar is causing injury. So the people weren't ever told any of these things. They were just given the medicine because that's what doctors know. They know medicine. You got this, I give you this. You got that, I give you that. There could be something simple with no medicine, and that would be no carbs, no sugar, no hot tamales. Don't eat the hot tamales. Well, what do I eat instead? A good source of protein, a good source of fat. That's it. Well, what else is there? Those are macronutrients that are essential. There's essential fatty acids, there's essential amino acids. There are none, zero essential carbohydrates. You could live without them. You don't need them. But because you live in prosperity and abundance, you think you deserve them. And no meal can not include your carbohydrate, which is not needed, but it's causing your diabetes. And the diabetes is causing your heart disease. But your doctor tells you only to concentrate on LDL, saying that if I lowered your LDL to 70, 50, 60, whatever it is, below 70, you won't have a heart attack. Yet you have a heart attack. Let's just look into the future. You have the heart attack. And then they'll tell you, well, you know what? You were way too gone. We were way behind the 8 ball. We could have never. I'm sorry that this happened to you, but hey, we fixed the artery, stay on the statin, it'll never happen again. Although people who have the coronary artery bypass graft are now more at risk of getting more heart attacks, even in that same area. Their risk goes up over 50% of having plaquing occur at the area of the bypass graft. Did they tell you that? Well, then you say, well, should I have just left it? Well, I don't know. Did you have collateral flows? Yeah, they told me I had collateral flows. And you didn't have any heart disease? No, I didn't. Why do doctors push statins so much? I think I answered that. Because they're treating the very thing they've been told that causes coronary artery disease, LDL. Statins lower LDL. They don't lower VLDL, they lower LDL. VLDL is dependent on your diet. If you eat carbs with sugar that raises insulin, VLDL, which carries triglycerides, will be elevated. You stop eating them, in 72 hours, your VLDL/triglyceride level will be lower. Like in the 70s. 3 or 4 days, recheck it. Don't eat any carb. Check your triglyceride of 200 and see what it is in 4 days, no carbs. Looking for questions here. Mandy, that is quite a family history, and I'm sorry to hear about all that. I don't know if there was a question in there, but if there is, let me know. P-Dub says, I had 2 strokes several years ago. Now, about 6 months ago, I developed my hands shaking and severe tingling from my shoulders to my hands tingling. And my hands and arms, shoulders swell. Is it nerve damage? I think you need to see your doctor, P-Dub. If you would like to consult, I would be happy to walk you through some things, but on this, I don't think that I would have the capacity without knowing a whole bunch of information and taking up a lot of people's time for other questions. So if you would like to consult, email me at IronLadyDoc@AOL.com. Melanie says, happy Thanksgiving. Hope you had a nice day with your mother and furry friends. Thank you, Melanie. Hope you did too. I appreciate that. So if you would like to consult with me, IronLadyDoc@AOL.com. IronLadyDoc@AOL.com. I want to thank RM for being an awesome moderator. It is much easier to get through the questions that are appropriate. Mandy, again, it sounds like you got a lot going on, and I think it would be more appropriate to, during a consult, to, we can go through these things, but you really should talk to your doctor about it. Olive says, tamales aren't junk. Bad example. Tamales, I said hot tamales. That is junk. Those are candy. Maybe you don't know what hot tamales are. Carl, it sounds like you have, you need to see your doctor about your urinating problem. Olive says, I'm so glad I do some trends. I don't know what that means. I did Whole30 for 10 years, and I learned a lot about my body. Congratulations, that's awesome. Olive says, my dad died of a heart attack last year. 3 months before that, he said to me, I think I'm addicted to sugar. He was addicted to sugar. Everybody who eats sugar is addicted to sugar, especially if they can't stop eating sugar. Mandy says, my husband died the day after his 42nd birthday. They said atherosclerosis. I'm not sure I agree. Well, how can you agree? Did they give you proof? Did they do, after the fact, did they do an angiogram on him? Did they do a CT angiogram? Did they do a regular angiogram? Did he have an autopsy? Was his arteries, because of atherosclerosis, greater than 70% blocked? Or, your husband, the day after his 42nd birthday, he got so stressed out during his 42nd birthday, something happened. He triggered a blood clot formation, and the next day he dies of blood clot blocking his arteries, and poof, MI. Congratulations, Mandy made it to 43. She was fearful about her 42nd. The day after her 42nd, she made it to 43, and she listens to her body. That's awesome. Carl, I'm not going to answer your question. In fact, if you want to continue right there, I'm going to hide that. There we go. So Carl's gone. Ryan says, I'm addicted to sugar and grew up in a sweet shop. It affects my concentration. Well, if you know that you're addicted to sugar, then you need to get some help. Mood Elevator says, I'm so happy I found you today. Finally, someone saying the truth. So Mood Elevator, if you think that I am helping you, could I be helping somebody else? Share my stuff, subscribe, click the thumbs up, do the like, do the clickety-clack stuff that gets me and my material elevated so more people can learn. I don't get anything for this. It's free. I do this every Saturday and Sunday, free of charge. I don't charge you guys to listen to me, give you free information. So if you like what I say, or it opens up your eyes and ears and brain to start working and think through some other avenues, then share it. Please share it. I want to help more people. That's why I stopped seeing patients in my office. I could only see 10, maybe 14 if they were fast ones. 15 at the most, because I spent so much time with them. And if I'm talking one-on-one to 10 people, when I could speak one-on-one to 3,000 people right now, whoa, I could be affecting, whether I'm right or wrong, I'm affecting 3,000 listeners instead of just 10. So I believe the payoff is greater online than it is in the office. And if you think that doctors make a huge amount of money, the only way they make money is by seeing and churning patients through their office. The more they see, the higher the codes, the more they make. The more procedures they do, the higher they make. If you are me and seeing 10 patients a day and spending an hour with them, maybe not quite, do you think that doctor is making any money? One code, one patient, 1 hour, when the other person is seeing 10 in 1 hour with higher codes? Yeah, you guys are getting the picture. It's not about money, guys. It's not about money. If you're humble enough to admit to yourself, really dig that person out of your inner core and say it's not about money, you'll understand. Marion says, I've had type 1 diabetes for 60 years and wouldn't be alive if it weren't for the fantastic doctors and nurses from our wonderful in the NHS in the UK. I'm happy for you, Marion. Congratulations on making it 60 years. Olive says, yes, sorry, I didn't hear the hot part. Yes, candy is delicious poison. Yeah. A lot of people love hot tamales. It's a little bit of fire with a little bit of jelly and a little bit of a crunch. It's perfect. The global flavorists did awesome when they could, you know what the best thing they could have done is added a little salt. They would have added salt to that hot tamale, or maybe you already thought of that. Then they would have had the perfect combination of addiction. Mandy, that's congratulations. That's awesome. Yeah, I forgot about that one, Jambo. I should have mentioned that. The red dye number 30 and blue and number 42 and hot tamales. But thank you for adding to that. I appreciate that. That's a loaded question, and I don't know where it even went, but there was Anandan is 25, wants to live to 125. What should they do? That would be a good question for me to go through everything on a consultation. But you should sleep good and pray good and exercise and follow a low carb diet and get out in the sun and decrease your stress and do all that, and you'll have a better chance of making it to 125. Yeah, Brian, I agree. Postmortem would tell what the arteries looked like. We will get rid of that one. Type 1 BSS is a type 1 diabetic for the last 21 years, but healthy. That's awesome. So a healthy type 1 diabetic is one that needs very minimal insulin. Insulin is a problem. When we eat carbs, we're going to need more and more insulin. Whether you're a type 1 and have to dose it, or you're not a type 1 or a type 2 and you eat it, your pancreas will have to produce it. So either way, hyperinsulinemia, insulin resistance is the #1 cause of coronary artery disease. So if BSS didn't need any carbs, then BSS needs very minimal insulin. The amount of blood sugar that we need in our bloodstream at any one time in order to survive is 5 grams. That's 1 teaspoon. But we, as adults that will eat more or consume more blood sugar than needed, which will require more insulin, which will lead to coronary artery disease. You guessed it. What blood sugar levels cause damage? I believe anything over 80. Brian is 66 with 3 autoimmune disorders. I'm sorry to hear that. Olive says, can we talk about gum disease weakening the heart? Are you familiar? Well, why do we have gum disease? Let's just start from question 1. What causes gum disease? Gum disease, itis, gingivitis. Itis is inflammation. What causes inflammation? Could it be bacteria? Could it be tartar that builds up because of bacteria? Could it be mouth breathing that builds up tartar, which irritates the gums and then we don't get it cleaned out on a regular basis, and it builds up and causes more gingivitis, inflammation. And then that bacteria that grow in our oral biome, it's the bacteria that are the cause of heart disease. Those bacteria that love to make tartar are also responsible for irritating the lining of our arteries and leading to coronary artery disease. If you think that simply using a mouthwash, antiseptic, to destroy those bacteria that cause gingivitis, you're kind of on the right track. But what if the mouthwash, antiseptic, killed good bacteria too, which the good bacteria in our mouth secrete nitric oxide. If nitric oxide is no longer there, then we don't have any type of antioxidant. Nitric oxide in our mouth is like an antioxidant or an antibacterial. So you took an antiseptic that you wanted to kill the bacteria that kill tartar or make tartar and cause coronary artery disease, but yet you're also killing your good bacteria that release or secrete nitric oxide, which is your natural antibacterial. It kind of defeats, it's a double-edged sword, you guys. So the cure: don't eat things that increase itis of the gums. Get your teeth cleaned and the gums, so deep cleaning, so you avoid the itises and you avoid those bacteria. But those bacteria love to eat the foods you consume. Sugar. So my answer is low carb diet and keeping your teeth clean yourself by brushing them, maybe with a good hydroxyapatite toothpaste, using dental floss or something similar, like those little pick things that you rub back and forth through all of your spaces. Teeth cleaning maybe every 3 months, 3 to 4 months. Maybe you're a tartar producer. Maybe you're a cavity producer. Usually you're one or the other. If you're a cavity producer, what causes cavities? Sugar. If you're a tartar producer, what causes the tartar? The bacteria that feed on the sugar. So in all reality, keep your diet as low carb as possible. Keep your mouth shut and breathe out of your nose. Keep the tongue pressed against the roof of your mouth as much as possible, and get your teeth cleaned by a professional who can do deep cleaning around those gums to keep them healthy. Mandy says, my grandmother was the first coronary care nurse in West Virginia. Oh, hold on, I just lost it. Yeah, if you guys start writing questions, I can't keep it. Patty Waller and Blanche Piles, I know the heart extensively as well. So Mandy's saying she knows the heart extensively as you are very intelligent. I don't even know how you popped onto my page. Well, share my stuff. Maybe we can get the word out. But thank you for the compliment. I appreciate it. Johnny says, I'm an embalmer. I have a body with acute coronary insufficiency. What does that mean? I don't know. What is your diagnosis that would cause acute coronary insufficiency? Is it blocked arteries? Is it congestive heart failure? Do you have AFib? I don't know. Sacred Turtle says, I'm also happy I found you. I have very high cholesterol markers and have been told it's genetic and there's nothing I can do. Let's just say it is genetic, Sacred. Let's say you have familial hyperlipidemia. Does it say that you have familial small dense LDLemia. Are all of your LDLs small and dense? If they are, they're oxidized and you have a problem. You are at high risk for coronary artery disease. If you're one of the very minority of familial hyperlipidemia patients who have a certain, I think there is a certain pleomorphism that increases your risk of blood clots. Those people who have a subset of familial hyperlipidemia that have a certain propensity to make blood clots, you are a setup. There is no amount of statin that will lower your risk of having a blood clot. You could take the statin. I might even tell you to take a low dose statin. Why? Because statin's only mechanism of action that I truly believe in is one as an anti-inflammatory and two as an antithrombotic. But I think both of those things can be done with diet, exercise, stress-free, sleep better, get in sun, have more nitric oxide, all of that versus taking a statin. So Sacred, I would want to know, what is your breakdown, your particle size? Get in an advanced lipid test. Get a calcium scoring test. Get a CT angiogram if you think that you have soft plaque developing. Just knowing that you have hereditary high cholesterol, you could have all eaten bad. Did you think it's genetic, but did they do a genetic test on you to say that you had this diagnosis? Or did they say, oh, your dad had it, so you have it, so it's hereditary and it's genetic? No. A true genetic familial hyperlipidemia is diagnosed with a genetic test. You don't just assume. What if you ate crap like your dad ate crap and their dad ate crap? And you see what I'm saying? Then you call that genetic? No, that's hereditary bad diet. That's hereditary diabetes. That's hereditary insulin resistance. That's hereditary stress. That's hereditary not in the sun. That's hereditary no sleep. Those are not genetic disorders unless it's a genetic disorder. Olive says, like, subscribe, join. Once she learns she needs a small membership following, example, $1.99 a month. I do have $1.99 a month on my Instagram. Yeah, Olive, share it. I think eventually, once you get enough followers, from what I have seen on other YouTubers, is they start doing super chats. If you guys value me enough, there's no reason to do a super chat. You'll want to support me. You'll say, hey, I think I want to support this chick. She's doing this for free, and here's $10. And you say, thank you. That was cheaper than my copay to go see my doctor, who gave me absolutely no advice. Just read the guidelines, diagnosed my blood work, and gave me the thing. So it's up to you. Am I going to falter either way? Am I not going to be able to pay my bills? I've been going for 2 years already doing this for free, and I've been able to pay my bills. Okay? I'm not going down. I'll pick up cans on the side of a street if I have to. But this information, whether it's true or not, needs to get out there. You need another avenue. You need to open up your brain and stop letting people indoctrinate you with things they want you to know. You're not using your brain like a robot. You guys are so easy. Not you guys, you're listening to me. And so your brain is starting to open up. But stop being radicalized. They're isolating you. They're putting you in an echo chamber. They're tribaling you. They're doing everything they need to do to keep you so narrow-minded that you will fight your neighbor, your brother, your sister, your mom, your dad, your coworkers, because you think you're right, and they're just going to divide you. They would rather have you on the fringes than in the middle. This is the exact game plan. Okay? So by you guys opening up your brains, you're going to start thinking and using discernment and wisdom and knowledge, because you've looked things up. You're starting to look things up. And somebody will say, oh, I looked the exact same thing up that you did, but through AI. Well, AI is programmed by whoever is feeding them. And if the LDL camp is feeding AI all the information, AI is going to spit out LDL information. But if you talk to AI as if they are really a person. I do this all the time. I'll say, you're lying to me. And I will give them the reason why. And they'll go, oh gosh. They will come back and actually give me a compliment. Good point. Now you're starting to think. But here, let's unravel this. You know what I'm talking about. Let's unravel this and let's talk about it. Let's break this down. Isn't that what AI always does? Let's unravel it. Let's unwind this a bit. And then they'll give a little bit of information that you agree with, and then some information that agrees with the LDL camp. You know how it goes. But if you work the AI and you ask the right questions and trigger them to give you, but you have to be open to supplying AI with more information in order for AI to spit out information, the correct information, or else it's going to be one-sided, just like Google. I mean, it's like Google on steroids. Jeremiah says, I would love to hear your thoughts on pharmaceutical companies pushing medications. There's probably a time and a place for a medication. It is in the time and the place is in the person who does not want to do anything else and believes that a medication is their savior. So they need a savior and they don't want to stop any of their living in abundance and prosperity. They don't want to deprive themselves. Could a medication be good for them? I guess. What do I think about the pharmaceuticals pushing the medications? Well, if you were in sales and you were selling Michigan hoodies, are you going to say, I hate Michigan? Michigan sucks? Well, that's not going to get your Michigan hoodies sold. You're going to say, my medicine, my Michigan hoodie is top performance, and they're going to beat Ohio State, if not this year, next year, or last year, or whatever year. I'm going to sell, even if it's cheap material, you're going to try to sell your Michigan hoodies. So pharmaceuticals are just trying to make a buck. They want to grow just like you want to grow. They want to make money and pay their bills. But there's a difference in, I might say, hey, I don't know if you want this Michigan hoodie. It doesn't have the drawstrings for the hood. You see that? It came out and I didn't restring it. So with honesty, you could sell the Michigan hoodie to someone and you would put on a disclaimer and says, hey, you're going to need a cord for the hood. And then they'll go, hey, thanks for telling me. I could have chosen that one without with the string already in, but I really like that color. And the clash of the blue, the blue and maize, I really like that on that gray background. Pharmaceutical companies don't think like that. They're going to manipulate their data that even if this was without a cord, they're going to tell you that that's in style. And nobody has the cords. And the thin material, that's in too. You mean the see-through stuff? Perfect. The thinner, the better. It'll make you feel like you're not wearing anything. This is how they're selling you something. They're manipulating the data. Some of it might be right on, spot on. And then 80% is all brainwashing. They're going to feed the beast. The beast is LDL or the infection. Well, how do you prevent the infection? I just need the antibiotic. No, how did you get the infection? Well, I got bad gums. How did you get bad gums? You see, but if a person lives in prosperity and abundance and they don't want deprivation, they're the perfect one to get suckered in by the doctor who makes a diagnosis and gives you the medication, which is sponsored by the pharmaceuticals. I mean, it's typical of supply and demand. So that's my thoughts on it, supply and demand. Olive Juice says, I found an MD who owned her practice and spent an hour with us each. I hope she's enjoying retirement. I bet she is. Charlie says, bless you, and bless you back. I appreciate that. Um, I don't understand that. My inner core says, get out and drink something with your company. I don't know what that means. Mandy says, not to mention the long hours, mandations, and heartbreak that comes along with practicing medicine. But you're assuming, Mandy, that all doctors have empathy and sympathy. I don't think that you could paint a broad stroke and say you're presupposing that all doctors have heartbreak. I will tell you that that is not true. I have seen them. They don't have heartbreak. The reason they don't have heartbreak is because they don't have empathy. They might have cognitive empathy. They might say, oh gosh, I know how you must be feeling. No, you don't, because they don't have empathy. They're only reflecting cognitively the empathy because you're showing empathy. It's like a mirror. Until you see that, and I'm not even going to paint a big broad brush and say that not all doctors have empathy, but I'm just saying don't go the opposite and say they all got, and it must be heartbreaking. Now, from my perspective, it is heartbreaking. I have seen patients of 27 years die of the very things that I was trying to help them from. That can be heartbreaking. It does twist my soul a little bit. My heartstrings are tugged on when a patient dies. And that reminds me of you people that are on Instagram right now. There was a gentleman who has been a patient / friend for a couple decades. And he's been on the Instagram, and his name is Dennis Long. And that was his handle, Dennis Long, and then a number, I can't remember. Well, about 3 days ago, maybe 4, I get a message on my phone, and it was from his wife that he passed away. And she found my number in his phone and said, Dr. Jensen, I know that my husband you used to call my husband, and you guys would discuss computers and discuss keto diets, and he thought highly of you, and I thought you should know. I was no longer his doctor because I was no longer seeing patients. He had another doctor. And it broke my heart. I went into shock when I heard this message. Like, I couldn't believe it. In fact, a couple weekends ago, I noticed that he wasn't on. And I kept telling myself, maybe you should text him because he was my friend. He helped me with my computers, and he helped me with my internet, and he made some calls for me, and he did these nice things because he thought a lot of me. I remember I got him involved in doing TRX a lot of years ago when TRX was just getting, and he did it. He hooked the TRX up in his basement, and he did all the exercises, and he would come in just to tell me about his exercising. It was the cutest thing. This old man, and he would come in and what did he pass away of? I don't know. His wife doesn't know. Do I have my suspicions? Yeah. Could he have started keto decades ago and he would have avoided all of the inflammation and the coronary artery disease and the congestive heart failure and the AFib and the this and the that and the everything's? Yeah. It's possible. But we can't do the shoulda, coulda, wouldas. And he had a beautiful life. He's got grandkids that got to know him. And it's beautiful. And we hate to see people die. It's hard. On many of us, it's very hard. But I look back, and especially after talking to his wife, my memories are all the positive ones. And she actually said the same thing. Let me get rid of that. Oops, that was the wrong. Let me get rid of, I gotta hide a user here. There we go. Okay. So I guess I just want to I wanted you guys to know, and somebody dear to my heart passed away, and he made an impact on in my world, and I'm thankful for that. It's being a doctor is heartbreaking because I probably have 1,000 patients that could pass away tomorrow, and I will be heartbroken. But I know for a fact that Dennis was a believer, and because he told